Good morning, dear colleagues and chairs. As you know, vitrectomy is growing in popularity as a first-line procedure for retinal detachment. However, in spite of the advances in surgical techniques and technology, retinal redetachment remains one of the most severe complications of vitrectomy. The major causes of redetachment are missed breaks, opening of old breaks, or new break formation. To reduce the risk of failure of vitrectomy, we can either combine with scleral buckling or perform 360 laser. Scleral buckling, according to some studies, does not increase the success rate, and according to EVRS detachment study, it has a higher failure rate when combined with vitrectomy. In theory, application of 360 laser may reduce the rate of redetachment by walling of any detachment that might occur anterior to the barrage, and it may treat any missed breaks unintentionally. In this study, we assessed the safety and effectiveness of intraoperative 360 prophylactic barrier endolaser photocoagulation in preventing redetachment after vitrectomy for detachment. In this study, 50 eyes of 50 consecutive patients who underwent 23G vitrectomy for primary detachment were enrolled. This is a prospective and randomized study. And our exclusion criteria are pediatric patients, PVR grade C1 or worse, giant retinal tears, eye trauma and traumatic detachment, proliferative diabetic retinopathy, stiffness of the retina, and the need for retinectomies, and a follow-up less than 3 months. Our surgical technique was a standard 23G vitrectomy. And at the point of laser, we randomly assigned the patients into two groups. In the local laser group, we only performed laser around the tear. And in the 360 group, in addition to the local laser, we performed 3 or 4 rows around the equatorial area and posterior border of vitreous base. The demographic and baseline clinical characteristics were similar between groups. The initial detachment characteristics, including number of breaks, localization of retinal breaks, and extent of the detachment and macular status and PVR were similar between groups. The single success anatomic success rate and mean best corrected visual acuity were similar between groups. The mean follow-up was 8 months. The single surgery anatomic success rate was 92% in total, and it was similar in both groups, slightly higher in 360 laser group. One patient in local group redetached after silicone oil removal, none in 360 group. The ultimate anatomical success rate was 100%. Complication rates were statistically similar between groups. It was consisting of epiretinal membranes and macular holes. Interestingly, we only saw 2 macular holes in patients in 360 laser group. In the literature, there are many articles about the use of 360 laser. It seems to be effective after vitrectomy for macular or other vitreal diseases, and it reduces the redetachment rates after silicone oil removal. Iwase and Barada et al. Made a similar study like ours, and they also published that 360 lasers made no difference in preventing redetachments. Peripheral breaks after vitrectomy usually occurs along posterior margin of vitreous base, mostly around sclerotomies. Schneider argues that in the absence of observable PVR, postoperative vitreous base contraction does not appear to be a clinically relevant problem in non-complicated detachment cases. In our study, 16% of all detachment patients had postoperative ERM, but only 4% of them required surgery. Crawford indicated that broad application of laser aggravates experimental PVR, but this hypothesis is not backed up in clinical trials. We observed 2 postoperative macular holes in 360 group. It may be because of left posterior hyaloid, macular microcystic degeneration caused by either detachment or surgical inflammation, and tangential traction of epiretinal membranes. In conclusion, Vitrectomy without the 360 peripheral endolaser can provide successful anatomic outcome and functional improvement in uncomplicated primary retinal detachments, and excessive laser photocoagulation during vitrectomy may be related to macular hole formation. Thank you for your attention.
I've just got one thought. It's more of a philosophical approach, really. I wonder how much what gas I use and how much laser I do is treating me more than the patient. And I'm a firm believer in perhaps now in an era where we have so many toys and adjuvants, etc., that it's easy to do more. And I wonder whether we should be doing less. What's your feeling on lean surgery compared to belt braces and oil and encirclement and laser and everything else?
In those fresh retinal detachment patients, I agree with you. I prefer a minimalist approach to the surgery. So I agree with you. Thank you for your comments.